Good afternoon, everyone, and thank you so much for joining us. Welcome to the fourth EMIC webinar, the Emergency Manuals Implementation Collaborative. I'm Jim Sachetta, and I'm going to be your host today. I'm a project manager at Ariadne Labs working on the Safe Surgery team, and it's my pleasure to introduce my co-host, Dr. Alex Hannenberg, who will be leading today's webinar with me. Alex is a faculty member on the Safe Surgery program at Ariadne Labs. His work is focused on the implementation of crisis checklists for critical event management in the OR and beyond, and he is also a past president of the American Society of Anesthesiologists. And finally, we are super excited to be joined today in person by Dr. Alexander Arriaga. Alex is an assistant professor of anesthesia at the Harvard Medical School and an anesthesiologist for Brigham and Women's Hospital. And he's also the assistant program director for the Brigham and Women's Hospital Anesthesiology Residence Program. Welcome, Alex. Thank you so much for joining us.
Very excited to be here. It's amazing how much Ariadne has grown in the years. I remember this being a research group, and now it's kind of an enterprise, an organization, an entity. Thanks so much for the invitation.
Glad to have you. So before we start, I'd like to run through a few webinar functionality items with all of you. We're going to be keeping the phone lines on mute to cut down on any background noise. But if at any time you have any questions or comments, please feel free to use the chat function that's located on the right-hand side of your screen. Or you can also directly raise your hand, which is also located on the right-hand side of your screen, and we'll be able to unmute your line so you can ask a question out loud. Sorry, we're having technical difficulties with our slides here, of course. Well, while I handle that, why don't I introduce Dr. Arriaga. Alex is the assistant professor of anesthesia at Harvard Medical School and an anesthesiologist at Brigham and Women's Hospital. He completed his undergraduate studies from Columbia University and graduated from the medical school with honors in research from Cornell University. He completed 2 years of categorical general surgery residency at Thomas Jefferson University Hospital, and he has a master's of public health and a doctor of science degree from Harvard University. He was a member of the faculty of the University of Pennsylvania for 2 years. He's presented both locally and nationally. Dr. Arriaga has over 35 co-authored publications, including 2 book chapters as senior author. His peer-reviewed published works include first author original research studies in the New England Journal of Medicine, which we all know very well, and he is one of 7 members of the Patient Safety Editorial Board for the American Society of Anesthesiologists. He's also an affiliate faculty member for the Center for Surgery and Public Health and its SHARP program, and he is also an associate faculty member here at Ariadne Labs. Alex, very strong background. We've worked closely with you over the years. It's wonderful to have you.
Great. So three of the key areas in which you've contributed knowledge, obviously crisis checklists, also team training, and more recently the value of real-time debriefing after critical events. And we'll have the opportunity to touch on each of those in the next few minutes. I always think of Arriaga is to checklist as Armstrong is to space travel, kind of a household name. And it's now been about 6 years since you published the simulation trial of the crisis checklist in the New England Journal of Medicine, probably the most persuasive piece of evidence supporting the value of these tools. So in the intervening years, looking at what has happened with the use of checklists, has there been anything that surprised you?
I mean, a lot of things have, and thank you again for the invitation to be here and that very kind set of introductions. I think that the global use of these checklists and the adoption, translation into many different languages has been very encouraging. The broad growth of EMIC, the Emergency Manuals Implementation Collaborative, in that you have a set of leaders and organizations that have embodied that possibly the discussion right now is not, which specific version to use, but the idea that these cognitive aids and emergency manuals are intrinsically valuable. Kind of more anecdotally, it's always surprised me that these paper checklists have still kind of stuck around. And I think from the very beginning when we were working on this, granted this topic has been worked on for decades, including in many other industries and Stanford, and the list just goes on and on, but that people are like, hey, can't we just build an app for that? Hey, can't we just make this electronic? Can't we have a QR code? And I think that there's some success stories. There's the success stories from the Society of Pediatric Anesthesia, some of the great work that Dr. Marshall and Dr. Burian have published on design. But there's something, from a behavioral psychology, cognitive psychology standpoint that in the setting of an emergency, that aspect of a piece of paper as opposed to kind of pushing a bunch of electronic buttons, I've anecdotally found surprising.
Yeah, there aren't a lot of moving parts in a loose leaf binder. So one of the things that most proponents of emergency manuals have encouraged has been the modification of crisis checklists for local needs, and that would be both modifying an existing checklist, but also the creation of additional checklists for your practice. So you devoted a lot of time and energy to validating the power of the checklist in that simulation trial. What's your feeling about the level of validation required for the safe and legitimate use of a crisis checklist developed locally?
Yeah, I think that less emphasis needs to be placed on, validation per se, as opposed to just ongoing measurement and implementation. I'm a huge fan of your implementation toolkit that you developed and kind of have, readily available on the Emergency Manuals website. I had the pleasure of being at another institution that didn't have emergency manuals or crisis checklists, and I think that the goal there was the notion of building a set of people that were behind this that was multidisciplinary, having your contact in the pharmacy, having a nurse that's on board, having a surgeon that's on board, and then having a set of anesthesiologists and team that know what's going on with some sense of kind of monitoring for use. I feel like, I would hope at least, that some of that paper has shifted the emphasis away from a need to kind of validate per se, as opposed to, like with any initiative, you want to implement it properly and you want to kind of follow it over time to make sure it's still meeting your needs.
Right. So in there is, am I hearing the message that by virtue of creating the checklist in a multidisciplinary way, there is a multidisciplinary vetting process that's intrinsic?
Yeah, I enjoyed the fact that, another example I didn't bring up was biomedical engineering, that this unleashed, how many different defibrillators there were all over the hospital system, the vetting of making sure that there isn't something on the checklist that refers to medication that's not on your formulary, and the list, realizing exactly where that surgical airway cart is, even if it's behind something, knowing exactly where the fire extinguisher is, even when your eyes are closed in an operating room you work in every day. All of that vetting that takes place sometimes the benefit of the vetting is not just to the customization of the checklist, but to kind of improving your system itself.
Now, this is a hard question, but given the experience in healthcare generally, in the operating room particularly, layered on top of the experience in other industries, have we reached the point where the use of crisis checklists should be mandated by some regulatory authority, CMS or the Joint Commission, or take your pick? Have we crossed that threshold?
It's a very fascinating carrot and stick question of, have there been enough, is there enough momentum and enough carrots to kind of go in that direction? you're preaching to the choir in that I do think that these are intrinsically very valuable and are supported by a lot of evidence. I always find it fascinating when I see other regulatory requirements that, there's an ongoing discussion about bouffants and whether they should be on top of a clean kind of surgical cap, and yet you have a topic like this that has a lot of evidence. I do acknowledge that, unfunded mandates require resources in and of themselves, and these things are very delicate conversations to be had. But, if any of those regulators, Joint Commission or elsewhere, ever want to have me over to talk about the evidence or at least, give my take, I'm more than happy to.
Yeah, great. It is a touchy subject.
Mm-hmm.
So you spent some time as a research fellow with Dr. Gawande. We were just talking about the fact that was actually before Ariadne Labs was founded, and you became interested in team training and with debriefing as a component. How did you get interested in that subject?
I think it's one of the key events that had me switch fields from surgery to anesthesiology. Kind of was a major impetus in me getting the Doctor of Science from the Harvard T.H. Chan School of Public Health. I did have a slide deck kind of available, so I'm hoping that you can see it on the webinar. But what was happening at the time was that Kryko, who sometimes has the reference or name of, or is referred to as the Risk Management Foundation of the Harvard Medical Institutions. They're officially
our malpractice carrier.
Yeah, your malpractice carrier. Thank you for translating that into English. They had an initiative that Harvard has some major academic institutions. Amongst the big academic ones, the thought was, could they put those four institutions together to work collaboratively as a team, together with the Harvard T.H. Chan School of Public Health and Dr. Gawande, towards developing a team training program that would be scalable. Also, one of the fathers of anesthesia patient safety, Jeff Cooper, was instrumentally involved in that, and it was just at the time an offer. How could anybody turn that down? The ability to get a doctorate from Harvard, working together with Atul Gawande, Jeff Cooper, these four major institutions, all on this team effort, bringing the anesthesia patient safety movement and a lot of its training and crisis management to the whole team. It was a no-brainer for me, and I was very grateful to be part of that.
So you published in Annals of Surgery in 2014 describing that project and the findings. Can you give us a little capsule of what those results were?
Absolutely. If you could advance to the next slide, I talked about it briefly. So while it's advancing, basically we ended up recruiting over 220 participants across the four simulators, and each team contained one attending surgeon, one attending anesthesiologist, and a circulating nurse, or two nurses and or surgical techs. The teams were about 7 individuals in size, so they were very representative. And I think if you go to the next slide, it might kind of point out, the active operating room participants. As you can see, I have like a printed version of that slide since it's a bit small from where I'm looking, but it represented the gamut of different people that commonly work in the operating room. And if you go to the next slide, some of the things we found fascinating, other than the fact that it was viewed to be highly feasible and very well accepted, was what people wanted to work on. If we, of the participants that we asked, what, if anything, do you want to work on when reviewing these crisis simulation events as a team? Communication was the predominant thing, followed by assertiveness, then followed by, yes, let's brush up on ACLS protocols and do a bunch of other things. If you go to the next slide, since a lot of this talk was about debriefings, I kind of, and for the sake of time, some of the questions that we asked them, going on the decades of experience of a lot of the patient safety individuals that were involved in this study, people felt comfortable, open, able to discuss their concerns. They felt that we had created a safe environment, and that these, on a survey that we asked them, this was consistent across domains. It was surgeons, anesthesiologists, nurses all felt that something good had been pulled off. And if you go to the next slide, I don't remember. Yeah, it was approved by CRICO for a multi-million-dollar rollout to train, in the order of hundreds of surgeons, 400, and the associated operating room team. So it was a big success story.
So that interest stuck with you in a way when you went to the University of Pennsylvania, and the question that you focused on morphed a little bit from the use of debriefing in simulation training to the prevalence of debriefing in following real-time critical events in the operating room. And that is the topic on which the Anesthesia Patient Safety Foundation and the Foundation for Anesthesia Education and Research have recently awarded you funding to pursue the question of how to make that more prevalent. What did you find when you looked at that?
Yeah, I was I am incredibly grateful to Dr. Lee Fleischer and those at the University of Pennsylvania. It was a family effort. Like, it was just so many people involved in that study, looking at real events, like kind of just leaving the simulator and actually seeing that gap between principle and reality and what was actually happening, at the bedside. I do have some slides on there if you happen to still have them, but there was really three big, I was going to go to the take-home, but just briefly on the background, if you go back one slide, there's opportunities for medical education, mitigating the negative impact, burnout, wellness, also opportunities for fixing the system with learning what can be happened, but for some reason there is that gap between principle and reality. If you go to the next slide, and I think what also fascinated me in particular is that these are the events that are on these cognitive aids, that they're part of this emergency manual. And there's a lot of these reasons that people bring up in terms of why it may not happen at the end of the day in the real world. But
interrupt. When you refer to the gap, you're referring to the gap between the understanding of the value of debriefing in multiple domains that you just enumerated, and the fact that they don't happen that much.
Correct. If you read the literature, debriefing is embraced across multiple specialties as a valuable thing to do after a critical event, yet for some reason at the end of the day it doesn't often take place. If you go to the next slide. And in the study that was published in Anesthesiology, we looked at real critical events. We audited and interviewed on about 90 events. It was predominantly audits and interviews of anesthesiology residents, just based on the resources that we had. And we had a couple of take-home findings. One is that these events were spread out all over the hospital. Only about 40% of them were actually happening in the real operating room. I'm just reminding myself I kept that slide in. If you go to the next slide, you can see, and it really speaks to the ubiquitous nature of anesthesiology residents, that they're spread out all over the hospital system, and it also speaks to the growth of non-operating room anesthesiology. But only about 50% of all of these events had any type of debriefing, and we were very generous with what we defined as, any type of a proximal debriefing, and that there was this very fascinating relationship that we found with communication breakdowns, that if the event pertained to complex medical physiology, this patient was old and sick, there was more of a tendency for people to debrief these events as opposed to somebody got under your skin, in which case people walked away upset, and maybe the same thing happens next week to the next team type of thing. And on that note, it was incredible to work with two specific people, Rachel Sweeney, who's now a med student at the University of Pennsylvania, who was really kind of at the forefront of collecting a lot of this data, and Dr. Justin Clapp, a medical anthropologist, who really, we worked together to deem out some of those social factors that play into it.
So you've described several different scenarios in which debriefing could occur or couldn't occur, namely bad physiology, disruptive behavior, communication breakdown. Is the nature of the debriefing in those different kinds of events itself different?
So at least for this particular study, we tried to, as I said, be very generous with what we defined as any type of a proximal debriefing discussion about the event in a dedicated conversation during the event or shortly thereafter. But I think that that's the active area of research in the question. Every institution could benefit from customizing, which events they think are best for debriefing relative to the resources they have available to them and the local culture, and what type of debriefing should specifically take place. There's a lot of principles of debriefing, like using advocacy inquiry, inviting people to participate, screening to see if a safety event should be filled out, whether a peer support person should be engaged. And yet, for some reason, even at that bare level of core principles, 50% of the time in this study, we saw that there was that gap of it not taking place. And of course, there are the barriers of real life when you step outside of the simulator, and that's what makes this type of translational work so fascinating.
It is indeed, and this is a little bit of an unfair question because you really haven't begun the work under the APSF FAIR grant. But any preliminary thoughts on what a strategy to bridge that gap might be, and in particular, starting out with the observation in a university medical center, what does it take to make an approach to bridging that gap scalable in different clinical environments?
Yeah.
So it's a multi-part, completely unfair.
Unfair and multi-part, I'm game for it. To kind of take apart the question, one thing in terms of that has come up and growing in the literature is within team debriefing. This notion that the team itself could have some component of a debriefing amongst each other, as opposed to just waiting for the safety officer 2-3 days later, or waiting for, to get back to the simulator a few months later, or whatever a given institution has available to them. There is also this notion of whether things could be scalable with online video technology. Could we have training sessions that are scalable that then could kind of serve as that impetus or nidus for there to be some type of within-team debriefing at the bedside. And then I think a third thing would be leveraging what your hospital already has. There's growing momentum towards physician wellness and avoiding burnout, and a lot of resources that are either talked about or created, but drawing that connection between a patient safety project on debriefing, within-team debriefing, reviewing critical events, and maybe, whatever's available to a given institution or health system in terms of peer support, in terms of mental health, or in terms of other, initiatives to improve the quality of care of the healthcare system.
Well, so it's interesting citing what I think is very prominent in most people's minds, this idea of provider wellness and burnout. When you talk about simulation and debriefing, and probably more so in the event of a real clinical event, the risk of psychological distress, not only from the event, but having the debriefing compound that. So on the one hand, we're talking about the opportunity to debrief and reflect and share thoughts after a real critical event as contributing to provider wellness, but I know the simulation community is very focused on avoiding psychological distress from the debriefing. Sounds like razor's edge in there somewhere.
Oh, yeah, and I think with the utmost respect for that concern, which is a very valid one, I also hope that this work and others can destigmatize the fear of having a debriefing because of that reason. There is, at one level, a separation between the medical factual and the affective or emotional. I think that in doing this work that at least I've been involved in, there's a lot of providers that just want a sense that they didn't do anything wrong. And I think that 2-3 days later, or even, beyond that, I think that you're kind of extrapolating with someone who actually wasn't there. Well, they're kind of more focusing on sometimes the effective part of it, but the medical factual is kind of hard because you're talking with someone that wasn't part of that team that was involved. again, like I am not, you know, a mental health professional, but many institutions do have these resources available. And if you could have a scalable moment at the point of care, at a pause point after these events happen that don't need to disrupt, you know, the production pressure that exists in these operating rooms, you know, could this not only improve the quality of the physicians, but kind of improve the healthcare system as a whole?
Right, so you raised an interesting point, the production pressure as barrier to investing the time in doing this. There's also potentially a personnel cost related to having people expert available to step in. So either way, this is kind of the time is money phenomenon being illustrated here. Either way, there's an investment. And, you know, will health systems make that investment? And if you were arguing for the value, what is the return on investment? What's the value proposition to a healthcare system for taking this on?
Yeah, well, I think that, you know, and I am not a business manager, but I do think that there is a good call to, you know, the value of it. On one end, in the previous question, you talked about whether or not there was these negative, affective, or emotional components in us doing this study. A lot of participants, you know, with our data collectors said that they felt good just talking about the event, you know, so there is that potential positive impact on the provider. But to be more businessy, I actually brought with me the Patient Safety book by Charles Vincent and an article in the California Review Management from Tucker and Amy Edvinson, where they even kind of bring up a little bit of a business call, not specifically on debriefing, but this idea between first-order problem solving and second-order problem solving. And, you know, and the equivalent is, you know, that let's say that your bear hugger is missing, oh, let's steal it from the next room. Like you're fixing the problem for your case, you're getting through the day, but the system itself hasn't, you know, that workaround didn't generate some type of a fix. So I think that, and, you know, they even make a value proposition for, a business value proposition for how second-order problem solving can be financially a good idea for an institution. Again, this article is not about debriefing. It's their 2013 article, Why Hospitals Don't Learn from Failures. But I think also there's that sense that these, this point-of-care mini debriefing or whatever could be done in a good way could also bring the team together to avoid what sometimes is referred to as these retaliatory safety reports, you know, where one person thought this and they thought of filling it out, and now the healthcare system has to figure out from that account and collect people together. What if the team was having a point-of-care debriefing, and then together they submitted something, you know, about how the system could potentially be changed? Again, every different critical event will have their nuances, but there are some value propositions that could be made for this ritual.
Right, so that question is related a little bit to the idea of, and maybe this will come up in the development of the protocol for your project. What would you test to understand whether you are in fact generating value in some way from implementing real-time critical event debriefing?
Yeah, well, I mean, I think that there's a lot of potential things that we can try to sort out what could actually be learned at the point of care. And I do thank many of the collaborators that are involved in this APSF and FAIR grant, in that is part of the emphasis that we're looking at. It's not just whether or not debriefing is taking place, but what actually could be made different. And you know, what providers are learning at the point of care. It doesn't change the value of doing a debriefing at other points in time with other particular people, but there might be things as simple as making sure you're all set for the next case, particularly if the event involves some type of an equipment issue that could be done at the point of care and kind of could create some rapid correction.
Right, so there's a time-honored tradition in medicine, the morbidity and mortality review that we've been doing for probably at least a century. Clearly, given the gap between where we are and ideal care, it isn't necessarily meeting our needs. How does the concept of critical event real-time debriefing relate to morbidity and mortality review as we currently know it?
So I think that one thing that's beneficial about this debriefing is that it doesn't necessarily have to involve a morbidity or a mortality, in that you can, again, bringing up this second-order problem solving, you can potentially fix the system as a team, even in events that don't necessarily cause the M&M, that could be more of a near miss, or even something more distal to the near miss, that people can discuss as a team. Routine debriefing has been embraced, for a long time, or has also been lauded as a safety principle. Why can't critical event debriefing provide some of that value without it having to exclusively be part of an M&M? From an M&M standpoint, though, it could potentially also, put together some perspectives of what happened before it shows up on Wednesday morning or Monday morning or whatever, whatever day of the week M&Ms take place at different departments.
Right, and one of the features of the traditional M&M is that it is a department-based event, and unlike the critical event real-time debriefing, it is uniprofessional. So presumably if you go into the operating room after a near miss or a calamity, you've got the full range of the professions involved. Does that teach us something about the best way to do morbidity and mortality conference?
Yeah, I would certainly hope. I mean, I think many institutions will sometimes invite someone from the other departments, especially if they were involved in the event, and there are multidisciplinary grand rounds. But again, with these types of rituals regarding proximal debriefing, could we, augment the frequency and quality of these things happening in a multidisciplinary fashion?
Right, to pick up on another concept that is growing interest, namely apology and disclosure, do clinicians who participate in real-time debriefing have an advantage in preparing themselves for apology and disclosure to patients and families?
That is a great question. Anecdotally, I would like to say yes, and it has tremendous face value for being for making sense. I can't cite a specific piece of literature or study that has specifically looked at that question, but in my own involvement with critical events, I do think that pause point of coming together as a team and having some type of a structured sense of what took place could only make that message more, that much more valuable and multidisciplinary when being discussed with the patient, which many times does happen, at least to an extent, at the point of care.
Right. So are there other points that you'd like to make before we open this up to audience questions and reactions?
No, this was great. This was an impressive amount of ground to cover in a short period of time. A little bit, on team training, a little bit on debriefing, and then, of course, thank you again for all of the great comments about the crisis checklist. I welcome any questions from the audience.
I just have one question, Alex, before we start. I've been hearing this, and it just seems like you started in 2013 or pre, and it just seems like you're digging deeper and deeper and deeper. Do you see that maybe there's a bottom to the end of this hole, or are you finding that there's more and more topics and that this is just broadening the field in general?
That's a great question. No, I don't think in my lifetime that there will be an end to these many topics. There's also the preoperative phase, could we capture some patients before the crisis takes place, in terms of surgical appropriateness and getting at that end of it. There's the postoperative realm. I enjoy very much that, the APSF and FAIR grant, some of the suggestion was the language of, even considering these perioperative crises, to not even exclusively label them as anesthesia critical events or surgical critical events. And, that's a whole nother bag of worms, the amount of things that have taken place outside, the amount of anesthesia that's provided outside of the operating room, and the opportunity for so many other disciplines to get involved.
Great. Great. Well, we're going to open it up to the audience to see if anyone has any questions. I'm going to unmute everyone's line, and feel free to ask your question aloud. Hold on one second. All right, everyone's lines are open. If anyone has a question for Alex, please feel free.
Hello, everyone. My name is Komal Bajaj. I'm based out of New York.
Hi.
Hello. I'm the Chief Quality Officer at one of the municipal hospitals. This is a great discussion. Alex, I'm curious, as you're embarking on this journey, or, the experience that you've had thus far, how did you approach faculty development for, sort of the various teams who were implementing?
That's a great question. I think the last word or so, I was starting to hear some background noise, but the question of faculty development is a great one. And by the way, it was great to be introduced to you, via email a few weeks ago by Dr. Alex Hannenberg for the CRICO team training project, which the emphasis was on each team having at least one attending anesthesiologist, one attending surgeon, and an operating room nurse, plus a surgical tech or two nurses. That had a lot of thought had to be put into how to properly motivate or create a mechanism for which faculty could be engaged. It did seem as if on the anesthesiology and nursing side that by working with the departments, there was ways to figure out how to involve them and have some backfilling, some acknowledgement at an institutional or department level or malpractice level that this was valuable. I do acknowledge, surgeons are very, there's a different value proposition that needs to be made in terms of their caseload, their RVUs, and in that end, we were very grateful for the work with risk management. But it doesn't change the fact that when working multidisciplinary, smaller interventions or scalable things or things like video and online could be created that are not as restrictive to having to go to spend half a day somewhere to do a specific multidisciplinary training.
Yeah, that's fantastic. Thank you, Alex, and look forward to sort of working on this together. In my health system, we're embarking upon just at the very beginnings of a system-wide post-clinical event debriefing program, and sort of bouncing around the tiered levels of development. And certainly what you described, video or sort of an online module for kind of expectation setting, was something that we were thinking about doing.
No, that sounds great. I'm excited as well.
Right, so in there is this question of who in the multidisciplinary team is optimally positioned to take on the role if there is a facilitator, regardless of who that individual is or what professional role they occupy. What is it that they need to know to do it capably, and how do they get to know that? Putting all of that aside for a moment, you mentioned one of my favorite topics, which is within group debriefing, which is at least in simulation-based learning as opposed to real hot debriefing, appears to be a highly effective alternative. And it addresses all kinds of things, like the question we just asked is how do you train somebody or develop faculty to do it, and also the scalability. So whether the experience with simulation-based training and within group debriefing can be transferred to real event debriefing, I guess, is an open question, but it sounds as though there's at least some possibility that you may help answer that question.
Oh, yeah. No, I'm very hopeful, and I am a fan of Dr. Boe. I don't want to mispronounce his first name. Dr. Sylvain Boe over at the University of Ottawa has done some great work on, at least as you mentioned, within the simulator and kind of growing work on within team debriefing. I'm hoping that as we develop some way to improve debriefing in a way that's generalizable, scalable, and valuable, that we can help to move that needle.
Thank you so much for the question. I'm going to unmute all the lines again, so if anyone else has any follow-up questions, please feel free to voice them.
Alex, would you like to address that?
I think it's a great question, but I'll leave it. I'm glad we have a multidisciplinary audience, or multi-species audience. Yeah.
Okay.
Alex, I just posted on the chat. Do you have a Twitter handle? There's a lot of Alex Arriagas.
Oh my goodness, I don't really use Twitter. I do have I do have a handle because I had to do it for a talk I had to give. But thank you for asking. I'm opening up my app right now, and I can tell you. I think it's my first name and my last name, Alex Arriaga.
It sounds Kamal, but you're probably not going to see a lot on his feed.
It's at Alex Arriaga 1234.
Thank you.
All right, well, if there aren't any more questions, I will mute our lines again and start to wrap things up.
I don't want to monopolize the time if there are other folks that have questions. Otherwise, I do have a follow-up question.
Yes, please.
So this is truly remarkable and fantastic, and again, I can't wait to sort of have a kind of meeting of the minds and brainstorm. I'm curious about, as you're embarking upon this journey, we've been thinking about process measures, sort of outcome measures and balancing measures. And, one of the things that we've been really sort of debating back and forth is that, on one hand, as you said, people feeling like there's not enough time is a huge barrier to post-clinical event debriefing. And so we were thinking about looking at responses or left without being seen in the ED as a potential balancing measure. I'm curious sort of kind of where your head is at, or what are you thinking as far as specifically balancing measures for this kind of program?
Well, and that's such a great question. We didn't specifically study the number of minutes it took for, particular debriefings amongst people that didn't. But, it did seem, and this is in part why it was so fascinating to work with the group at Penn. I do miss that very much, in that working with the medical anthropologists, there did seem to be this sense that we interviewed a lot of participants, and yes, there's production pressure, yes, there's a lot of things to do, but there was this sense that if the people involved in the event wanted to debrief, for some reason that debriefing took place, and if they didn't want to debrief, it didn't take place. Sometimes these events, looking at the operating room example, happen at 10 o'clock at night where you have a whole bunch of ORs empty. They happen at times where there is both time and space available, and that the real answer to this is not just thinking about, 11 a.m. on a Tuesday where, there's 5 add-ons and, how are we possibly going to make time for this? There is also that sense that this debriefing doesn't necessarily need to be a prolonged ritual, that at least at the point of care, certain critical things can be kind of overviewed without having, and possibly serving as a triage for something more valuable later.
Yes, in thinking about the question of how do you insulate this from things like production pressure, I was expecting your answer to be something about, high-level institutional executive buy-in.
Mm-hmm.
That's not what I heard. So you want to say something about whether you think, from what you've observed, that that's essential, or is that nice to have?
Oh, no, I think that in every project I've been involved in, both research and non, that leadership level buy-in is certainly probably one of the most important pieces of proper implementation. I think getting the chair, getting the hospital system, getting these people to buy into, hey, even if this does take a couple of extra minutes, perhaps this is something very valuable that the entire team should do. Maybe this is another one of those preaching to the choir thing. I think that these rituals are tremendously valuable. I think that I tried to take it to the other extreme and maybe assume that no one thinks it's valuable. How do we still kind of make the case for it? But certainly I think, kind of going to that realistic stage in the middle, I would hope that there would be leadership buy-in, thinking that, supporting that this is valuable, plus the respect that certain things can be done without taking too much time.
Great. See, the less you ask of leadership, the more likely you are to get it. Share
leadership
observation for many years, yeah.
Mm-hmm.
Okay.
Any other questions before we close things up this afternoon? All right, well, thank you so much to both Alexes. Well, when we had some technical difficulties earlier, we weren't able to share that EMIC will be at the ASA annual conference again this year in Orlando. We've got 2 EMIC-sponsored events. We've got our annual EMIC Open Forum on Monday the 21st at 4:30 to 6, where we'll be talking about unintended consequences of emergency manual use. And then on Tuesday afternoon, we've got a workshop entitled Approaches to Training in the Use of Emergency Manuals. Alex, did you want to share any additional color on either of these topics?
Right. So Alok Agarwala, now of Mass Pioneer Infirmary, Jason Cheng of Kaiser Permanente, and I will be talking about different ways of overcoming the print and plunk phenomenon and what can be done to help clinicians effectively use emergency manuals.
We'll be sending out more directed email marketing about those specific events, and we hope to see you in Orlando. I'd like to, again, just point everyone to some resources that we discussed today. We've got our emergency manual implementation toolkit website that's constantly being updated with new resources and materials, and is a great resource for anyone beginning the implementation process. And also the EMIC website at emergencymanuals.org. We'll soon be posting these webinars there as an additional resource. We also have our OR Emergency Checklist online community on the Ariadne Labs web portal, where we've got a discussion forum there where it is a great resource to get in touch with us and other EMIC steering committee members. And finally, I'd just like to thank Dr. Alex Arriaga for joining us again.
Indeed.
It was wonderful to have you and hear more about your growing body of work, and we look forward to seeing you in Orlando in October.
No, thanks for having me. Yes, I look forward to being there as well.
Thank you very much.
And thank you, everyone, for joining.
Thank you. Bye-bye.